I think the technology puts the most liked questions at the top. So the most liked questions are, Thomas Hoffman has asked us whether there are objections to continuing opioid therapy in very high doses when the patient is doing well. Would you like to answer that, Aya? That's on.
Well, first of all, if a patient needs a dose which is 500 milligrams, then the first thing that I would do is to measure plasma concentrations of morphine and its metabolites, and consider whether there is something specific in that patient's pharmacokinetics regarding morphine. And if the patient is doing well, if that means that the patient has good pain relief, quality of life has improved, and also the patient sleeps well, the patient is functioning better, and there are no troublesome adverse effects, and the patient is adherent, then I don't see any reason for changing the medication. But then also those adverse effects that are maybe not so easily identifiable, for example, the effects on the hormonal function and immunological adverse effects may also need to be considered. And the final issue is that is there a possibility that the patient actually is not taking all the 500 milligrams, and therefore checking the blood, the plasma concentrations is important also for that reason.
I would just like to make one comment that's been a bit of a game changer in the UK, that we have new drug driving legislation. It's not an offence to drive when taking prescribed opioids, but what we know from the science that informed the drug driving legislation is that for patients who are chronically taking opioids in a dose of morphine equivalent to more than 220 milligrams per 24 hours, they will be equivalently impaired as if they were over the legal limit for alcohol and driving. So I think that has had quite an impact on how we advise patients taking high doses, because we now know that a patient taking 500 milligrams of morphine a day will certainly, whether they feel it or not, they will be impaired. And I think that may well change patient choices.
Yes, but I really think that this combination of the patient feeling well and needing so high doses of opioids means that something is not standard, and you need to find out why this combination exists.
We have a lot of likes for what is the mechanism behind how opioid increases the risk of myocardial infarction. I have no idea, so I'll defer to my...
This is a difficult question, and I think one should really read carefully the epidemiological data. So maybe because in patients who have chronic pain, they also have more comorbidity. So one needs to be sure that the patients do not have other comorbidities that enhance their pain perception, which then may have led to the use of opioids. And maybe these patients are those who have not been able to take non-steroidal analgesics because they have contraindications due to their cardiovascular risk factors. So maybe it's a combination of many different factors, but I don't have a clear answer for that.
I would like to just answer one question that isn't on this screen, but I think we do have to talk about gabapentin and pregabalin. There is a question, do gabapentinoids have abuse or dependence potential themselves, or are they being used as additives and enhancers? And I think we don't know enough yet. We certainly know from large studies of prisoners that gabapentin and pregabalin are used for their, not to enhance the effect of other drugs, but are used for their central effects per se. And there are varied reasons that users will give for using them, but often they get an opioid-like high, they say. And misusers will often use much higher than doses we would prescribe. But also we think that anxiolysis is quite a driver for continuing use, because obviously it's a very, very stressful environment being in a prison, and sedation. So there was a very eloquent piece written in a prisoner newspaper that pointed out that if you're locked in a cell for 23 hours a day for several years, actually sleeping off your sentence with the help of pregabalin can be very helpful. And lots of strategies are used. So prisoners will drink each other's urine, because pregabalin is unchanged in the urine. So prisoners go to a lot of effort to obtain pregabalin, and amongst insecure environment settings, pregabalin misuse is a much, much bigger problem than opioid misuse in the UK.
Yes, I agree. And when having spoken with the addiction physicians, they say that the reason why opioid or individuals addicted to opioids, why they use gabapentinoids, and the most prevalent combination in Finland in the forensic studies that have been performed is pregabalin and oxycodone. So the reason really is that gabapentinoids have a significant anxiolytic effect. We also know that pregabalin and gabapentin, they do enhance opioid effects, but there are no pharmacokinetic interactions. And if someone is interested, there is a poster today by William Jokinen, and he has looked at the effects of pregabalin and oxycodone and morphine, both the enhancing effects of opioid effects, and also he shows that there are no pharmacokinetic interactions, that gabapentinoids do not increase the CNS concentrations of opioids.
So a question that the use of tramadol is present in Australasia. Should we take the same precautions to prevent tramadol misuse? Certainly our own guidance, when we last did guidelines in 2010, we encouraged thoughtful prescribing for all opioids, including codeine, tramadol, and the more traditional strong opioids. And certainly tramadol is now a scheduled drug in the UK, and it is classified in our prescribing directory, the British National Formulary, as a strong opioid analgesic. So very much so, we would ask prescribers to think about all opioid products, strong or weak, with the same caution.
And I think also the mortality data that we've seen in the UK, although there's been a large increase in prescribing, that has also been reflected by an increasing number of deaths that have been associated with tramadol as well. So I think it does need to be considered in exactly the same way.
Should we do the gabapentin versus pregabalin? Top one.
Oh, yes.
What are the magnitude of risks of gabapentin as compared to pregabalin when it comes to the risk of misuse? I think we don't know the answer. I think looking at the secure environment setting, it's what people can get hold of. But the go-to drug in drug misuse circles in risky settings and non-risky settings is pregabalin. I think patients will talk about pregabs. That's the latest thing that everybody wants to have, more so than gabapentin. But actually, there are data in relation to misuse of gabapentin. But as we know, the kinetics are different, are they not, Roger, of gabapentin and pregabalin? So pregabalin is more dangerous in overdose.
Yes, I would agree. And because of the faster effect of pregabalin, so patients do report more euphoria and well-being after pregabalin. And the absorption of gabapentin from the intestinal, from the gut is, so there's an upper limit to the absorption, whereas the absorption is linear with pregabalin. So in that sense, gabapentin should be, at least theoretically, be a safer choice than pregabalin.
I think this is very much Ayer's territory. 50% pain reduction. Is it not better to set the goal together with the patient?
Well, of course, the goals need to be set with the patient, but the research indicates that if the patient achieves at least 50% pain relief, then the patient actually benefits in improved sleep function and so forth. I think it is impossible to, in the clinical practice, say exactly that now you need to have a 50% pain relief, but this means that the pain relief needs to be enough so that the patient benefits also in these other areas, not just the patient says that, yes, I think this dose is good and my pain is less. It needs to have also other positive consequences in quality of life, sleep and functioning.
I think this is from Anonymous. It's a very, very pertinent question, and it's we engage thoroughly with the palliative care community in thinking about this. Do you make a difference between chronic cancer pain and chronic non-cancer pain? And certainly in the UK we don't. The title of our last guideline was opioids for persistent pain. The risks of opioids relate to the duration of use. And so now we have better cancer treatments, and we have cancer survivors, or we have patients who have a long prognosis from diagnosis. And we also have patients with persistent pain who then have a cancer diagnosis which they then recover from. And there is a National Institute of Clinical Excellence guideline on opioids for palliative care, and we emphasize the importance of a maximum dose of 120 milligrams a day, other than at the very last few days of life, and the importance of discussing long-term harms and benefits. So I think it's a very, very important question, and I think we need to be thinking about duration of treatment and exposure to harms rather than diagnosis.
Yes, so chronic pain related to, not related to cancer needs a very different approach compared to patients with cancer. And cancer survivors are regarded as patients who have non-cancer pain. And then within the cancer pain population, I think it's also the state of the cancer that makes a difference. So at the end stage of cancer, then of course the goals are different. But I think that also there is a paradigm shift in treating even terminal cancer pain with very high doses of opioids, because that may not be the right way. You need to find out why the patient is not responding to opioids, and also the fact that high doses of opioids may actually increase the patient's pain, and another strategy may be needed. I'm not saying that opioids should be stopped, but opioids may have to be switched to others. Other medications need to be added, and the most important thing is that to consider whether the patient's increased pain and lack of efficacy of opioids is due to anxiety and other psychological factors.
I think, there are lots of really interesting questions here, but I think we've reached the end of the session, and thank you very much for participating and giving some great questions, and thank you to the speakers for the session. Thank you.